Hello everyone, this is Chadi Alraies from Denver. This is CVI 2022. I'm privileged today to be with Dr. Abdul Oseni. He is one of the challenging case presenters coming from University of Oklahoma, and he's going to be soon starting his job in July. Welcome to Abdul to being with us.
Thank you very much.
So Abdul, you presented a phenomenal case talking about complexity and how to get about the thinking and about how to approach cases more than the case itself. Can you tell us about a case?
Yes, so this case was a challenging case that was transferred from an outside facility.
Yeah.
And the gentleman had heart failure with reduced ejection fraction and was getting admitted every 2 weeks for heart failure and non-STEMI, and nobody knew what to do with him. So they sent him to surgery. Surgery declined him because he had these stent grafts in his abdominal aorta bifurcating into the iliacs. So we eventually took the patient and decided to do it with axillary impeller, which was basically the only access we had. And
before you go there, I just want to go about the clinical decision of why the surgeon declined the patient. He said he has 3 vessel disease, correct?
So the reason the surgeon declined the patient was this patient is what we colloquially call a vasculopath.
Yeah.
Did not have any potential good veins. He did not have good grafts. His STS score was very, very high.
That's good, yeah.
So
Subjective way?
They rejected him for that.
Okay. And syntax score, do you usually routinely measure syntax score for these patients?
Not routinely. What we do is we eyeball the syntax score. If it looks low, you'll know it's low. If it's high, then you probably will calculate it. If it's intermediate and you really need to make a very, very hard decision on that kind of patient, then we have to calculate it. But studies have shown that 2 different people calculate them differently.
Absolutely,
so.
Exactly. So now let's go back to the patient. He has a hostile aorta, has bypass before or endograft done before.
Yeah.
So large bore sheath is unfeasible.
Out of question.
Yes. So what makes you go to axillary?
We have, at University of Oklahoma, we had pretty good experience with axillary access. Usman Barber, one of my mentors, has done a number of them, so we're pretty comfortable with getting axillary impelling.
And is your axillary access usually ultrasound guided or fluoro guided?
Both.
Both.
We actually put a wire through the radial artery for bailout and use the wire as a marker for where we're going to stick, then use ultrasound and fluoroscopic guidance to hit the wire in the angle we want.
Good, awesome. So let's go on with the case. So you put an impella axillary, and the reason for impella is because the patient has low EF, I'm assuming.
Low EF and left main into LAD disease, and we're anticipating we're going to use rotational atherectomy in that scenario.
Good, all right. So any circumflex disease?
Say that again.
Any circumflex disease?
Had some ostial to proximal circumflex disease, and had some OM disease as well.
Sure. So what technique did you use? Yeah.
So technique we used here, first of all, we IVOS the LAD to see if we needed to rotate, and it was moderate, so we abandoned the rotational atherectomy for the LAD. Then when we IVOSed the circ, it was 3-quadrant severe calcification, so we actually took a 175 bore to the left circumflex at that point.
And then what was your, I'm assuming you did bifurcation technique. What was your technique?
We used mini crush.
Mini crush.
Mini crush. And, there's an argument for DK crush at left main bifurcation, which is a well-studied kind of bifurcation stenting technique. But, there's a lot of data coming out of New York, especially Mount Sinai, that's showing that mini crush is as good as well. So
absolutely.
We elected mini crush because it was a long procedure. We've had some complications, which was when we put the impeller in, there was occlusion to the whole right arm. So we had to do a femoral to radial external bypass to counteract
So that was happened on the table when the patient is there?
Yes.
What was the sign and symptom? If the patient is sedated, was he complaining or?
No, he wasn't. The reason for that, we anticipated it was going to be a long procedure. So we wanted to minimize, if we couldn't minimize ischemic time to the arm, we didn't want him to lose his arm just because we're doing a revascularization. And we're doing this under ultra low contrast as well because of his CKD. So we use 10 cc of contrast for the whole procedure.
Mainly imaging, pure imaging.
Yeah, purely imaging and using previous imaging as roadmap to slip them into the monitor and use them as roadmaps.
So did you do a single axis impella for the intervention as well, or you had a different axis?
So the plan was for single access, but the problem was when we got in and we had the occlusion, we had to peel out the impeller sheath.
And you lost that?
Yeah, so we lost that. So we had to go through one of the endografts using a woolly wire to navigate. It took a while, but eventually we used a long sheath and parked it in the descending thoracic aorta.
Just above the graft?
Yeah.
And that was the donor for the arm for perfusion?
No, we had another access for it.
Another access for the perfusion, okay, all right. And then the mini crush, did you IVUS post?
Yes, we have a post to check for apposition and expansion, which was excellent.
Perfect.
Took a last 5cc angio, then
confirmed it, and
yep.
Awesome. So congratulations, very wonderful case. But I just want to highlight a few things. Is sometimes the planning is very important. You save a patient contrast, you save radiation, but also that you know what you are walking, like a war zone. You know the lay of the land. But the most important thing you mentioned is the imaging. You image the IVUS that makes you bail out on the atherectomy for the LAD, and yet you picked it up for a circumflex. Again, Abdul, thanks you for a good job. Well done.
Thank you.
And congratulations for the new job as well.
Thank you.
We'll look forward to see you in the future.
Of course, I'll be here every year.
Absolutely. Thank you everyone for watching this video, and watch this video and others on CVI YouTube channel. This is Chadi Alraies from Denver, Colorado.